I really wanted to do an internal medicine video today, but most of you actually pointed out that I do a lot of internal medicine videos on my channel, and I wanted to be different. That's how I came up with this video idea. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to look at two important topics in obstetrics and gynecology, predominantly obstetrics, which is premature rupture of membranes as well as preterm premature rupture of membranes, which I have abbreviated as PROM and PPROM throughout the lecture. If you haven't yet subscribed to the channel, please subscribe to the channel, hit the bell notification icon to be receiving notifications of such videos every time I post. Tell a friend to tell a friend that we are doing lectures on the channel. A big congratulations to all those that made it in their past exams, but to all those that are still in school and all those that want to prepare for internship, this one is for you. Here's a warm-up question, which is a true or false. Preterm premature rupture of membranes, PPROM, can occur if there is a history of PPROM. B, delivery should be expedited. C, is commoner in multiple pregnancies. Is there such a word as commoner? Anyways, a speculum examination should be done. You may write down your answers. You may pause the video at this moment. I will give you the answers at the end of the lecture. So when you talk about PROM, when you talk about PPROM, you want to actually keep in mind what exactly is term, what exactly is preterm. So if a baby is born after 37 completed weeks of gestation or pregnancy, we say that that baby is term. If a baby is born, or rather a baby is before 37 weeks of completed weeks of pregnancy, we say that that baby is preterm. So when you talk about premature or pre-labor rupture of membranes, this is simply just rupture of the fetal membranes and drainage of amniotic fluid before the onset of labor, occurring after the age of viability. In our setting here, we use 24 weeks. Some other hospitals use a benchmark of 28 weeks. And remember that rupture of membranes for longer than 24 hours before delivery is called prolonged rupture of membranes. In 80% of the patients that actually have rupture of membrane, 80% of them actually go into labor within 24 hours. I was actually thinking of having a labor week on the channel where I'm going to be doing different sections of labor and pretty much the management of labor in the subsequent week. So if you think that's a pretty great idea, please comment in the section below so that we can actually do that in the coming few days. Now remember that once the membrane has ruptured, the barrier that is preventing any infection from ascending is gone. So it means if labor doesn't occur or it doesn't follow within 24 to 48 hours, then we should induce labor because we want to prevent CHORIOAMNIONITIS, which is an intrauterine infection, as well as systemic neonatal infection, which does occur as a complication. Now, when you talk about preterm premature rupture of membranes or PPROM, this is where the membranes actually rupture before 37 completed weeks of pregnancy. And usually induction of labor may be an option in management. It's not always, because sometimes the child may be too young to actually survive outside the womb. In preterm premature rupture of membrane, there's actually significant maternal and neonatal morbidity as well as mortality. Remember that spontaneous rupture of membranes occurring greater than 24 weeks of gestation complicates about 2 to 3% of all pregnancies, and PROM affects 10% of all pregnancies. What are some of the risk factors? Like I said, in obstetrics and gynecology, if you've had the condition before, you had risk of having it again. So a prior PPROM history as well as a prior history of preterm labor, increased friability of the membranes and decreased tensile strength of the membrane. This could be associated with some collagen disorders, unexplained vaginal bleeding, placenta abruption, cervical incompetency, vaginal and even intraamniotic infection, amniocentesis, smoking, multiple pregnancies, polyhydramnios, chronic steroid usage, connective tissue diseases, anemia, as well as a low socioeconomic status. Tell me something that isn't associated with poverty. And a low body mass index, which is less than 19 kilograms per square meter. You may also have a cervical length that is less than 2.5 centimeters. Its cervical length should be somewhere around 4 centimeters. What exactly causes premature rupture of membranes? We don't really know what causes this, but there are some hypotheses that have been postulated. Some people say it's due to vaginal and cervical infections. Others say it's due to incompetent cervix. Others say it's even due to nutritional deficiencies, but the actual cause is largely unknown. What are some of the clinical features? So you will get a sudden gush of copious vaginal fluid. It may sometimes be trickling, and this causes the woman to be constantly wet. No pun intended. This is what we refer to as draining. Remember that draining should not be confused with another condition or another state which is known as hydrorrhea gravidarum, which is pretty much this periodic watery discharge that occurs probably due to excessive decidual glandular secretions in pregnancy. It should also not be confused with incontinence of the urine, which usually happens in the later months. When you perform a physical examination, and before I actually come to the physical examination, note that there isn't any significant bleeding. If this person has premature rupture membranes and significant bleeding, there should be also another underlying pathology that you should look out for. Then physical examination is going to be including an abdominal and a sterile speculum examination. Emphasis on the sterile speculum examination. You don't want to introduce any infections because the membranes are gone. So on external examination, there will be some clear fluid that is flowing out of the vagina. On speculum, sterile speculum examination, the liquor can actually be visualized as it's coming out from the cervical ostium, especially when the woman bears down or actually coughs. You may actually see the fluid actually pooling in the posterior fornix of the vagina. This is a clear watery amniotic fluid. You call this as a positive pooling test. You may also get nitrogen paper, and remember that nitrogen paper tends from yellow to blue because amniotic fluid has slightly alkalinic pH of about 7 to 7.5 compared to the vaginal pH, which is acidic, which is 4.5 to 5.5. When you get a bit of that sample and actually smear it on a microscopic glass slide and allow it to dry, then you view it under the microscope, you're going to be seeing this leaf-like pattern, which is known as fanning, which is pretty much crystallization of the sodium chloride in the amniotic fluid when you dry it. I'll show you a picture much later on of what it actually looks like. A bimanual examination should not be performed because this can actually introduce any ascending infections. And remember also, if a woman actually even has features of bleeding, do not do a vaginal examination, a bimanual examination. First get an ultrasound because you want to rule out placenta previa. Then oligohydramnios is seen on the ultrasound if you do get one. Then there is something that's known as latency, which is pretty much the period between the premature rupture of membranes and the onset of labor. So 50% of the women with PROM actually at term will go into labor within 12 hours, 70% within 24 hours, 85% within 48 hours, 95% within 72 hours. And remember that latency is going to be influenced by certain things. It's going to be influenced by the severity of oligohydramnios. Remember that severe oligohydramnios is going to be associated with a shortened latency. Multiple pregnancies, for example, twins have a shorter latency period than single-tone pregnancies, as well as the gestational age. Remember that 50% of women with PROM will go into labor within 24 to 72 hours, and then 70 to 90% within 7 days. Now, this is what a fanning pattern actually looks like over there. So our diagnosis is largely clinical. So we want to perform a sterile speculum examination. There will be a history of this woman continuously draining, the pooling of the amniotic fluid in the posterior fornix, the nitrogen paper test, as well as the microscopic fanning test, of which we don't even do routinely in our setting here. We just base it on a clinical diagnosis. You should order for an ultrasound. You could do a transvaginal ultrasound, which may show low liquor volume, which is oligohydramnios, and it's also used to assess the fetal well-being. Then the workup of the mother includes a full blood count with C-reactive protein, urinalysis, urine microscopy, culture sensitivity to rule out any UTIs, as well as asymptomatic bacteriuria. Get a cervical test or cultures for chlamydia trachomatis, as well as Neisseria gonorrhoeae. Get high vaginal swabs for bacterial vaginosis and trichomoniasis, rectal cultures for group B streptococcus. Then you should consider actually collecting vaginal pool for assessment, that amniotic fluid for assessment for fetal lung maturity, where we actually estimate the levels of phosphatidylglycerol and the lecithin and sphingomyelin ratios to actually tell if this child has matured lungs. Then, of course, we do an ultrasound for fetal biophysical profile. It's not done to support the diagnosis. And we may do a cardiotocography for a non-stress test. What's our differential diagnosis? It could be hydrorrhea gravidarum, like I already said, urinary incontinence. It could be liquefied sperms after intercourse. It could be just a normal vaginal discharge. And what's our management? So we want to confirm the diagnosis with a sterile speculum examination. We should note the state of the cervix. We should detect any cord prolapse. Avoid any vaginal examinations. Admit the patient to the antenatal ward or labor ward, depending on certain things. I will mention them later on. Then bed rest and placement of a sterile valve or pad to observe any further leakage can be done. Monitor the urine output, monitor the uterine activity, monitor the fetal heart rate, monitor the maternal pulse rate and temperature every 4 hours. And of course, assess for labor, chorioamnionitis, and even placenta abruption at least daily. An ultrasound should be done to check the presentation, the anatomy, as well as the liquor volume. Then definitive management depends on certain things. It depends on the gestational age of the infant. It depends on whether the patient is in labor or not, and if there is any evidence of sepsis or not, and the prospect of fetal surgical intervention that can actually institute delivery if delivery can actually happen. So if someone has PROM lasting more than 24 hours, we want to obtain cervical couches and start them on broad-spectrum IV antibiotics and initiate prompt delivery because they're already at term. So a C-section is indicated if they've had a previous C-section or if they have some contraindications to vaginal delivery. Then you may give them amoxicillin 500 milligrams 3 times a day or erythromycin 250 4 times a day for those that are allergic to penicillins. Amoxicillin can be combined with metronidazole, which is 400 milligrams 3 times a day. Amoxicillin can be combined with your erythromycin as well, but this is rather a very strange combination. So if there is no infection that is present, then the management is largely dependent on the gestational age. If it's before viability, before 28 weeks, the outcome is rather dismal. So consultant input is actually highly recommended. Involve your seniors. If the gestational age is between 26 to 27, steroids may be of some use. So a dexamethasone 6 milligrams IM twice a day for 4 doses can be given. Of course, labor induction with high-dose IV oxytocin and oral or even vaginal misoprostol can be used. Dilatation and evacuation after cervical ripening with misoprostol 400 micrograms per vaginally 3 hourly or sublingual 2 to 3 hours before the procedure. If the management is largely conservative, you want to closely monitor this patient for any infection, if they go into labor, if there is any placenta abruption, strict pelvic rest, so they shouldn't participate in any sexual activities. Then modified bed rest with bathroom privileges can be done, serial ultrasounds, and even oral antibiotics for the latency period. So the risks of fetal pulmonary hypoplasia is actually quite high with these individuals. Then for those that are preterm viability, that's between 28 to 31 weeks, then conservative management can be done. We hospitalize the patient, bed rest, give them our IV betamethasone. You can give 12 milligrams once a day for 2 doses, or dexamethasone 6 milligrams twice a day for 4 doses to enhance the lung maturity. Then we want to obtain some cervical couches, so a full blood count on admission, and start them on a 7-day course of prophylactic ampicillin or amoxicillin and erythromycin antibiotics. At term, we want to initiate prompt delivery. So if vaginal delivery is expected, we use oxytocin and prostaglandins as indicated. Otherwise, if a vaginal delivery is contraindicated, we can perform a cesarean section. So in term pre-prom, if uterine contractions occur, tocolysis is actually contraindicated. Do not stop the contractions of the uterus. Then C-section should be done if they have had a previous C-section. So here's our management algorithm. So the scheme or the schematic of PROM. So we want to assess the maternal health, the fetal gestational age, the weight, and the pulmonary maturity. Get a septic workup, that's your cervical swabs, your urine culture, and non-stress test, and a biophysical profile. So we want to monitor the maternal pulse, the temperature, the fetal heart rate, and start prophylactic broad-spectrum antibiotics as well as steroids, betamethasone. In our case, we often use dexamethasone. Assess in terms of amnionitis, placenta abruption, fetal death, or fetal distress, or if they progress in labor. If any of these things are present, we expedite the labor. We continue the intrapartum antibiotics broad spectrum. The child should be taken to the NICU. If it's absent, if the pregnancy is less than 34 weeks, expectant management to continue until the fetal lung maturity is assured. Then, of course, hospitals with limited resources can transfer these patients with the fetus in utero to a center which is equipped with the NICU. Bed rest, antenatal corticosteroids, broad-spectrum antibiotics can be done to prolong pregnancy and to reduce infectious morbidity. Then serial evaluation should be considered, and we should consider delivering them at 34 weeks if possible. Then if the pregnancy is between 34 weeks and 37 weeks, we wait for spontaneous onset of labor for about 24 to 48 hours. If this fails, then we induce labor with, of course, oxytocin. A C-section delivery can be done for all those that have non-cephalic presentations. For those that are 37 weeks and above, we wait for spontaneous labor to occur within 24 hours. If this fails, we induce the labor with oxytocin and C-section for the obstetric reasons if they need a C-section. Now, what are some of the complications? If the fetus actually remains in utero, there may be some neonatal complications like infections and sepsis, deformations, malpresentations, cord prolapse, umbilical cord compression, fetal pulmonary hypoplasia, especially in preterm premature rupture of membranes, placenta abruption, and then maternal complications include chorioamnionitis, sepsis, deep venous thrombosis, as well as even just psychosocial separation. If the child is delivered preterm, there may be some complications that are associated with prematurity. So your respiratory distress syndrome is the most common, patent ductus arteriosus, intraventricular hemorrhage, necrotizing enterocolitis, retinopathy of prematurity, bronchopulmonary dysplasia, as well as cerebral palsy. Now, what exactly is chorioamnionitis? Remember that the diagnosis is going to be made by the following things. You get a maternal fever, you get uterine tenderness, which is in the presence of a confirmed premature rupture of membranes. In the absence of any upper respiratory infection or any urinary tract infection, then you would actually assume that this woman has a chorioamnionitis. So we want to manage this with broad-spectrum intravenous antibiotics. So ampicillin 2 grams IV every 6 hours until 48 hours afebrile. Gentamicin 80 milligrams IV every 8 hours until 48 hours afebrile, and metronidazole 500 milligrams IV every 8 hours until 48 hours afebrile. Then start after delivery with the metronidazole. Then continue the IV medication to oral medication after this woman delivers. So here's a schematic of everything that I have been talking about. This is even going to be including the different parts and the different drugs and the different dosages and the different, of course, PPROM as well as term pregnancies that are undergoing premature rupture of membranes. So you can pause the video at this moment. You may zoom the video. You may increase the quality to actually have a look at this. It's a nice read up. So what about PPROM? Remember that this is just pretty much rupture of membranes before the onset of labor, so less than 37 weeks of gestation. The risk factors are pretty much the same as with PROM. So prior premature rupture of membranes or preterm premature rupture of membranes, unexplained vaginal bleeding, placenta abruption, cervical incompetence, vaginal or intraamniotic infection, amniocentesis, smoking, multiple pregnancies, polyhydramnios, chronic steroid use, connective tissue disorders, anemia, low socioeconomic status, and note that coitus, cervical examination, maternal exercise, and parity are not associated with preterm premature rupture of membranes. Now, what's the diagnosis is pretty much similar to what we had with PROM. The only difference is that this is happening in less than 37 weeks. Now, the general management, we pretty much admit the patient to the antenatal ward or the labor ward, monitor any uterine activity and the fetal heart rate, check the maternal pulse rate and the temperature every 4 hours, assess for any labor, chorioamnionitis, placenta abruption at least a day, once a day. Then, of course, the ultrasound for presentation, anatomy, as well as the liquor volume, get investigations, a high vaginal swab, endocervical cultures, urine cultures, and a full blood count. Of course, the white blood cell count in pregnancy tends to be actually changed. It may not be actually your usual normal white blood cell count. Then, of course, oral antibiotics should be given for the latency period, erythromycin or azithromycin and amoxicillin for 7 days. If possible, start preferably with ampicillin 2 grams IV every 6 hours for 48 hours, then transition them to amoxicillin for 5 days. Now, if this person is between 32 to 36 weeks, we induce or augment if there is no spontaneous labor within 24 hours. Misoprostol can be given if not contraindicated. Cover them on steroids. So dexamethasone 6 milligrams IV every 12 hours, twice a day for 4 doses. So usually the nurses or the midwives may have given the first dose if the patient meets the eligibility criteria. So we want to also send the amniotic fluid to assess for fetal lung maturity if it's available. So if you get a lecithin sphingomyelin ratio that is greater than or equal to 2, this means that the fetal lung maturity is actually assured and you can actually deliver. If the results indicate that the lungs are immature or it's unknown, then you can actually treat them with steroids and then oral antibiotics and then deliver them at 35 weeks. If they are at 28 to 31 weeks, we want a consultant to put in some input. Then, of course, we determine the gestational age to provide a realistic appraisal of the outcomes. Expectant management is usually done. We cover them on steroids either way, dexamethasone 6 milligrams every 12 hours for 4 doses. Then we minimize the mobility, encourage leg exercises and anti-embolic measures. We want to treat them with steroids and oral antibiotics and possibly deliver them at least at 35 weeks. Send a full blood count upon admission, then repeat if indicated. Then if the gestational age is 26 to 27 weeks, then steroids can actually be given. And remember that the options for labor or options for delivery include labor induction with high dose of IV oxytocin and or oral vaginal misoprostol, dilatation and evacuation after cervical ripening with misoprostol 400 micrograms per vaginally 3 hours or sublingual 2 to 3 hours before the procedure. I already talked about this. Then there is sometimes room for conservative management, which I did talk about much earlier on. Now, there is sometimes room for outpatient care. This is only done for the very compliant patients with PPROM who understand the risk. So the consultant's input should be required here. So we discharge the patients and we can consider them if they are for discharge if there are no signs of labor, if inpatient management is satisfactory after 1 week, and we tell them strict pelvic rest, so no coitus, no sexual intercourse. We check the maternal temperature twice a day, and they should return if the temperature is greater than 38. They should attend the antenatal day unit or the labor ward for a full blood count and a cardiotocograph twice a week, and they should attend the antenatal clinic at least twice a week. Then, of course, high vaginal swabs for any alterations in the vaginal loss or any alterations in the vaginal flora or any infections that may be there. Then we review any signs or symptoms of chorioamnionitis with the patient and advise her to return if she has any other concerns. Complications include neonatal complications that are related to prematurity, that's your respiratory distress syndrome, intraventricular hemorrhage, sepsis, as well as pulmonary hypoplasia, especially with those that have PPROM less than 22 weeks. You may also have skeletal deformities that are related to severity and the duration of PPROM. Maternal complications include an increased risk of cervical delivery, which is due to malpresentations, cord prolapse. You may also have intraamniotic infections, as well as postpartum endometritis. Here's a warm-up question. So preterm premature rupture of membranes, A, can occur if there is a history of PPROM. So this is true. B, delivery should be expedited. So this is false. It's not always the case that the delivery should be expedited. Then C is commoner in multiple pregnancies. It is. A speculum examination should be done. It should be done. And it should be a sterile speculum examination. I really hope you have learned a lot about premature rupture of membranes as well as preterm premature rupture of membranes. Jesus Christ. If you have, please consider subscribing to the channel. Hit the bell notification icon to be receiving notifications of such videos every time I post. Tell a friend to Zambia and beyond. My name is Dr. Moses Kazevu. Until next time, bye-bye.